Hello, everyone. This is Abram Kirschenbaum from Rutgers, New Jersey Medical School. My topic is upper limb reconstruction in cerebral palsy. I have no financial conflicts of interest to disclose. Cerebral palsy can be defined as an abnormal posture or pattern of movement produced by damage to the developing brain. The spastic form is most common, and it typically produces flexion at the elbow, pronation of the forearm, flexion at the wrist, and tightness of the digital flexors. It has changing manifestations in childhood, but it's important to remember that unlike the situation with multiple sclerosis, Charcot-Marie-Tooth disease, and ALS, in cerebral palsy, there is no progressive underlying neurological problem. The news from the epidemiologists is not good. The incidence of this problem is unchanged over the last 40 years in the Western world. This is probably related to improved survival of premature infants, as prematurity is one of the main risk factors for the development of this problem. And what that means is that as long as there are NICUs like this one that you see in the upper slide, there will be children with upper extremities that look like this one, and they will become adolescents and adults with limbs that look like this. So unlike the situation with polio or leprosy, two other formerly widespread paralytic diseases, there will be no vaccines or antibiotics to help us solve this problem. Commonly, cerebral palsy is present from birth, but there are many different ways that the developing brain can be injured. These include ruptured ABM, neurosurgery for intractable seizures, closed head injuries, and so on. And because the brain can be injured in many different ways, there are many different patterns of this disorder, including the swan neck deformities and thumb and palm deformity that you see here. One question we can ask when we see a hand affected by cerebral palsy like this one in the upper two slides is this a surgical problem? And I would submit that the answer is sometimes. This is not just a personal opinion. Van Heest in 2013 compared surgical treatment of patients with cerebral palsy affecting the upper extremity to therapy, Botox, and splinting, and found that in selected cases, the surgically treated patients did better. The good news from the literature in the field of hand surgery for this problem is that there are many different types of operations that can be offered to patients with this disorder. These include neurectomies, tenotomies, tendon lengthenings like the Z-plasty lengthening that you see here, fractional lengthenings that I'll discuss more in a little while, tendon shortenings, tenodesis, tendon transfers, and if none of these other procedures work, when patients get close to skeletal maturity, you can consider fusions. So I'd like to take you on a trip through the upper extremity. This first case is a 9-year-old male with severe spastic quadriplegia. He has bilateral elbow contractures that are interfering with his care. The goal of surgical treatment for this problem was to facilitate care, and the plan was a muscular cutaneous neurectomy and elbow release. The muscular cutaneous nerve can be identified near the shoulder. It's the most lateral structure in the brachial plexus, and in this picture at the bottom right, you can see the grounding lead for a nerve stimulator. So in the operating room, you can confirm that you have the right nerve. You can also test the effectiveness of a muscular cutaneous neurectomy with a preoperative lidocaine block. And of course, the neurectomy alone may not be sufficient in severe elbow contractures, as the muscles across the front of the elbow have often shortened significantly. Here is the diagram showing the surgical plan for a Z lengthening of the biceps tendon, and in addition to that, you can do a partial or complete myotomy of the brachialis muscle. In some cases of severe contracture, you need a skin graft at the front of the elbow, as you can see here, but at the 4-week follow-up, you can see that the posture of the elbow is much improved. The next case is that of a 10-year-old with hemiparesis and fairly supple wrist flexion posture with tight finger flexors, and the goal in this case was to improve function, and that was to be accomplished with a green transfer, the FCU to ECRB transfer. This transfer may also improve the pronation posture at the forearm, and it's important to remember to lengthen the finger flexors in order to prevent the development of a clenched fist posture following this transfer. Here are two diagrams to show the surgical plan. You can perform fractional lengthenings of the finger flexors, as you see here, through a volar incision, and the diagram on your right shows the plan for the FCU to ECRB transfer, where the FCU is swung around the ulnar border of the forearm. On your left, you can see the preoperative condition, and on your right, you can see that the hand is capable of opening and capable of closing, and functional improvement is pretty clear. Next case is a similar one. This is in a slightly older patient, 15-year-old young woman with tight finger and wrist flexors, and the goal in this case was to improve function and also to improve cosmesis. This is her on the left trying to make a fist. This is her on the right trying to open her hand. This is not just my bad photography, but it is very difficult for her to hold the right hand still when she tries to open it. Here are some pictures from the operating room. You can see in the upper left the resting position of the hand and wrist. In the lower left, and a photo of the fractional lengthenings. In the upper right, you can see a hole being made in the interosseous membrane so that the flexor carpi radialis can be passed through it. And then in the lower right, you can see the end result after the tapes are on in the operating room. Here's another case where you can see the flexor carpi radialis tendon being passed through the interosseous membrane, and you can see it takes a very straight course into the extensor carpi radialis brevis. The slide on the left here shows the flexor carpi ulnaris in the green transfer taking a fairly oblique course toward the extensor carpi radialis brevis, whereas in the slide on your right, you can see the FCR pass through the interosseous membrane takes a very straight course toward the extensor carpi radialis brevis, and this improves the effectiveness of the transfer. In this slide, you can see the pre-op condition, and the slides on the right are her making a fist and opening her hand at the first post-op visit. With some splinting and some therapy, the preoperative condition improves to the one that you see on the right, which represents a significant functional and cosmetic improvement over the pre-op condition. Next case is that of a 20-year-old female with severe spasticity and tight wrist and finger flexors. The goal for this patient was to facilitate care and to prevent skin breakdown at the wrist. Plan was for a wrist fusion and an STP transfer. In cerebral palsy and in most other cases these days, it's done with a wrist fusion plate like you see here. And on the lower right, you can see the game plan for the superficialis to profundus transfer. You cut the superficialis distal, you cut the profundus proximal, and if you sew them together, you can get the hand open. Wrist fusion in cerebral palsy typically requires a proximal row carpectomy, and the bones of the proximal carpal row can be used as bone graft. The STP transfer allows for more lengthening than the fractional lengthening that I showed you previously, and it certainly is less tedious than performing 8 separate Z-plasties of the finger flexors. The Z-plasty can be, the FPL can be Z-plastied, and through an incision at the thenar crease, you can do a release of the adductor pollicis in order to get the thumb out of the palm. Thumb and palm deformity is fairly common in cerebral palsy. It can be supple or rigid, and it was classified by House into 4 types. I think of them as the good, the bad, the unstable, and the ugly, and the instability is almost always at the metacarpal phalangeal joint. And it may require some combination of releases, transfers, and fusions in order to get the thumb out of the pathomechanics of the deformity are complex, and one or more of these procedures may be necessary in order to balance the forces acting across the joints of the thumb. Commonly, the adductor pollicis is released and the EPL is rerouted via the first dorsal compartment of the wrist. So here's a case of the thumb and palm deformity being corrected by the technique described by Paul Mansky. In this case, an ECU to ECRB transfer was also performed in order to correct the deviation in the coronal plane. But you can see on the lower left how the EPL tendon can be rerouted, and that turns it into an abductor of the thumb rather than an adductor of the thumb. Here's a type 3 thumb and palm deformity. You can see the marked hyperextension at the MP joint. This patient also had an ECU to ECRB transfer in order to correct the ulnar deviation posture at the wrist. And in the most radial portion of the incision, you can see the EPL tendon being rerouted through the first dorsal compartment of the wrist. The adductor was also released through this incision at the thenar crease. My preferred technique for thumb instability in the adolescent or adult population is the use of these compression staples, and you can see here that the thumb has been stabilized at the MP joint, and this procedure was done in this patient in conjunction with the EPL rerouting through the first dorsal compartment of the wrist. Swan neck deformities are also common in cerebral palsy. The pathomechanics are complex, but they involve some combination of extrinsic overpull and intrinsic spasticity. In severe cases, the PIP joints can lock in hyperextension, and even when they don't, this is still a cosmetic issue. The that I prefer was described by Zancoli and was also published by Van Heest in 2013. The procedure involves taking one of the lateral bands, typically the radial lateral band, and swinging it volar to the axis of rotation of the PIP joint. In the lower picture here, you can see the radial lateral band is sutured inside the flexor tendon sheath, and that will take away something that you don't want, that is overpull dorsal to the axis of rotation of the PIP joint, and give you something that you do want, which is essentially a check rein on the volar aspect of the digit. Here are on the top are 2 pictures from the operating room. You can pin the PIP joints in flexion for about 3 weeks, and that will usually serve to rebalance the finger. And the lower 2 photos, you can see the swan neck deformity, and here she is at about 9 weeks with significant correction. And you may be concerned, if you pin these small joints for 3 weeks, will you end up with fingers that are stiff in extension? Well, here she is preoperatively on the left, able to make a full fist, and at 9 weeks post-op, she can extend the fingers well and can also still flex them well. What about complications? The home team always gets to bat last. And so you do your surgery, and then the patient does what the patient's going to do. There are all the usual suspects: infection, nerve tendon injury, as well as stiffness. But in this field, the most common problems are overcorrection and undercorrection and late recurrence of deformity. Patterson in 2010 looked up 25 green transfers that his group did, and this was another one of those cases of good results ruined by long-term follow-up. Half the transfers had new or recurrent deformity, and that was a more common problem in patients who had surgery before 13. So this is a patient that I produced a supination posture in. And when I was training in orthopedics, they told me, before you do an operation, think of what could go wrong and have a plan for it. And the plan has to include more than just banging your head. So the plan in this patient was to create a one-bone forearm. You can put the radius on the end of the ulna, and you can put it in almost any position that you want. If your carpentry is good, these will heal, and you have created an ulneus. Here is the healed one-bone forearm. Here's the early result in the upper right, and the late result. Take-home message: in these patients, you can use basic orthopedic principles and usually the patient's own tissues for reconstruction, aside from the occasional plate or staple. You need to think ahead and plan for the long run. If you want to cure people, this is not the field for you, because at the end of treatment, the patient still has cerebral palsy. But if you want to help people, you can sometimes reconstruct, release, and grasp in a hand that is affected by cerebral palsy. And if you give somebody with cerebral palsy a little bit, you have often given them a lot. And these are some of my most grateful patients. I have time for a few questions. First one is in a patient with thumb and palm deformity. Which of the following will reduce thumb adduction and improve abduction? And that was the EPL rerouting that I showed you. Question: in the management of an intrinsic contracture without a skin deficit, which is the best incision for completing an adductor pollicis muscle slide? And when they say without a skin deficit, they're telling you that the patient doesn't need a Z-plasty of the web space or an incision there. And I showed a couple of cases of the thenar crease incision for the adductor release. The factor present preoperatively that predicts improved results in cerebral palsy. This one you just have to know. It turns out it's voluntary control. And the last question: 40-year-old woman had surgery 35 years ago at the age of 5, and that helped initially. Now she's got radial deviation at the wrist. You're supposed to know that she had a green transfer done, and so the correct action at this point would be to reroute or lengthen the FCU transfer. Fusion could also be considered, but it wasn't a choice. Thanks very much for your attention. I hope you enjoy the rest of the conference.